The brain and the spinal cord are perfectly mapped out. When there's a problem, usually the body tells us exactly where it is. You just have to know how to read the writing, or wiring in this case. Localization is the foundation of everything we do in neurology. Classic joke is that we can be replaced with a CT or MRI machine. The question isn't usually to scan, it's what to scan. Take, for example, you have a patient that comes in with increased falls on exam. You notice they have foot drop. Is it a stroke from their motor cortex, or is it a lumbar radiculopathy like an L5 nerve root compression, or is it just a peripheral nerve injury? Your exam will help you localize exactly where the lesion is. Are the reflexes increased? Is there weak inversion? Is there weak eversion? This is the power of localization. It takes the mystery out of the physical exam and turns it into a targeted logical search. Now, like everything in medicine, there are exceptions. There are some key general principles I will break down to make understanding localization much easier. Also, if you're going to neurology, you need to lock this drawing in.
As every consult you get, you should be running through this diagram to think about what could be going on, where their symptoms localize to. All right, let's get started.
At the very top, the cortex. If a lesion is here, you get motor deficits plus or minus sensory deficits plus cortical signs. There are three main cortical signs: aphasia, neglect, and gaze deviation. Neglect is typically associated with a right MCA stroke. Aphasia is typically associated with a left MCA stroke. And gaze deviation, you look towards the side of your lesion. So if someone came in with right arm weakness, aphasia, and a left gaze deviation, we would localize that to the left MCA region. For subcortical strokes, these would typically occur in the thalamus or the basal ganglia. Here we would have pure motor or pure sensory or a mix without cortical signs. So for example, if I had pure sensory loss in my right arm and leg, this would typically localize to my left thalamus. For cerebellar, the key rule is ipsilateral, same side. But a confusing co-founder is that large cerebellar strokes can also cause aphasia. Also, side note, a positive Romberg does not localize to the cerebellum. This is a sensory attack. Continuing our trek down the neuroaxis, we hit the brainstem. The absolute buzzword here is cross findings. So, for example, you have a patient that has cranial nerve deficits on one side of their face and then motor or sensory weakness on the opposite side of their body. You know you're in the brainstem. You can figure out what level of the brainstem by knowing your cranial nerve nuclei locations. The caveat here is large brainstem infarcts are going to be difficult to localize, and reflexes are not always consistent. Next, dropping down to the spinal cord, there's a lot involved in the spinal cord. We're kind of lumping it all together here. However, a dead giveaway that you're in the spinal cord is a distinct sensory level, i.e., as you're moving caudal to cranially with pinprick, you notice at the navel there is a distinct drop off in sensation. Your exam findings will depend heavily on whether the dorsal or ventral columns are involved. Ventral are typically more motor predominant and dorsal are more sensory predominant, but expect to see hyperreflexia and upper motor neuron signs below the level of the lesion. A classic board example of this would be something like transverse myelitis. Now we exit the central nervous system and reach the peripheral nervous system. Out here, the classic pattern is weakness or sensory loss that is worse distally than proximal. Think of a diabetic patient. They get numb in their hands and feet, but not in their thighs or shoulders. Think stocking glove, also usually symmetric, however, can be asymmetric. If it's an acute presentation, think Guillain-Barré syndrome. Also remember that Guillain-Barré syndrome is a demyelinating syndrome of the peripheral nervous system, but whereas MS is central nervous system. If it's chronic, think diabetes. Continuing our way down the neuroaxis, we arrive at the neuromuscular junction. When someone says neuromuscular junction to you, there are four things that I want you to think of immediately. First, myasthenia. Second, Lambert-Eaton. Third, botulism. Fourth, tetanus. For these diseases, think proximal over distal symptoms. Remember, myasthenia typically affects the proximal muscles, such as the shoulders. Typically, symptoms are symmetric, such as if one shoulder is weak, both are going to be weak. However, the exception would be cranial nerve abnormalities, so patients can have ptosis in just one eye. A key distinction between myasthenia and Lambert-Eaton is that myasthenia has preserved reflexes while there are decreased reflexes in Lambert-Eaton. And for botulism, remember this is a typical descending pattern of weakness. Next, as we continue down the neuroaxis, we arrive at the muscle. You have a patient that comes and sees you. They have fatigue as well as proximal weakness, trouble standing from a seated position, as well as trouble raising their arms above their head. You're trying to decide if this is coming from the neuromuscular junction or from the muscle. What to use to distinguish it? The answer is cranial nerves. Lesions that localize to the muscle should be chronic and progressive and not acute. Typically affect the proximal muscles greater than the distal muscles. Findings should be symmetric. Think about it. This is a systemic process. The findings should not be localized. Lastly, let's talk about upper motor neuron signs versus lower motor neuron signs. The classic example will be hyperreflexia for upper motor neuron and decreased reflexes for lower motor neuron. For upper motor neuron, a key finding would be clonus on exam, as well as increased tone or spasticity. Remember, spasticity is velocity dependent, where tone is passive. For lower motor neuron, key findings would be atrophy and fasciculations. And lastly, an upgoing toe or a positive Babinski on exam would be a sign, an upper motor neuron sign.